Okay, hello everyone again. For those who are with me for the last talk, this one's a shorter talk, I can promise you. So yeah, you won't stay too long. One question I just noticed, someone was asking about the sensitivity of this sign I mentioned, jolt accentuation, in the last talk. They mentioned that there's the Japanese diagram mentioned 97%. I don't know if that was sensitivity. I don't know what it said. And I don't know where they got that figure from. So it may well be 97% according to that study, if that was from a study. Anyway, so now we're going to talk about seizures and status epilepticus. And if you were with me for the last talk, you'll know that seizures are one of the 3 most common neurological symptoms presenting to the emergency department. And again, conflicts of interest. So I'm an epilepsy specialist. So I've talked before on sudden unexpected death in epilepsy. And we previously just covered headache and weakness. So on to seizures. We'll start with this. And there's no footage. This is from CCTV on the London Underground. And you're looking at this man here in black. And that was his father there who stopped him falling onto the passengers below. Okay. So I'll stop that there. That was from last January. And the reason I play that is because the Epilepsy Society that I work for is a charity to do with epilepsy. They use that to launch a campaign. They found that 2 out of 3 adults don't know what to do when someone has a seizure. Just because we're doctors doesn't mean that we automatically know what to do. So we'll cover a bit about what to do if you see someone having a seizure. And essentially, the campaign that they launched last year is simple. It has the 3 C's. So stay calm, which I think is very hard to do. Cushion their head. That's probably the main thing to remember in terms of what to do to the patient or person who's having a seizure in front of you. Keep their head protected. Don't try anything else fancy. And call for help. So I think that escalator was stopped pretty quickly after that seizure started. There are a few don'ts, and a lot of people, even doctors, don't know these. I've seen doctors do some of these and don't do them. So the diagram on the left is from Epilepsy Action, another UK charity, and the diagram on the right is from the CDC. So do not try and restrain someone. And definitely do not put anything in their mouth. Even if they've bitten their mouth and they're bleeding, don't put anything in their mouth. Don't move them. It's much better to move things around them, unless obviously they're in the middle of the road, for example. And certainly don't give them anything to eat or drink until they've fully recovered. The only exception to that is if you know they're diabetic and they've had a hypoglycemic episode, then yes, it's probably worth giving them something, squirting a liquid into the side of the mouth potentially, if you've got no other way of giving them some sugar. But yes, otherwise you don't want them to aspirate. And then you just wait. And during that time, it's actually quite a good idea to record the duration of the event, because that's very important for us in hospital. And of course, when we talk about status, time is very important. So someone has a seizure outside hospital, they get brought to hospital in an ambulance. The first, probably most important question to ask the patient, or probably more likely their caregiver, whether it's a relative or a friend, does he or she have epilepsy? Contrary to what you might think, there's actually 3 answers to this, and I'll come on to that, and I want you to remember the third one, and it's to do with this clip. So it's hard because this isn't interactive, so I can't ask you guys what you all thought of that. That was an example of a dissociative attack, or otherwise known as a psychogenic non-epileptic seizure, or a long time ago, they used to be called pseudo seizures, although we're not trying not to use that term now, or also called non-epileptic attacks. This is, well, you may have got that from the clue here. It's from the Current Psychiatry channel on YouTube. And dissociative attacks are essentially thought to be a psychiatric phenomenon, along with other dissociative disorders. That doesn't mean to say it's voluntary. We're not saying patients are malingering, but it's a complicated phenomenon, probably to do with the subconscious, but very common. And that's the reason I mention it. So we see it in about 1/3 of our patients in epilepsy centers. It's a statistic that really surprised me when I heard about it in medical school, but I can believe now is true from my own experience, is that up to 1/4 of patients admitted to intensive care and intubated with status actually have dissociative or functional or non-epileptic attacks. And of those that have dissociative attacks, almost half say they have been to an intensive care unit because of their attacks. There's also a long delay with diagnosis, which fits because they've been treated as epilepsy for so long. So they're on average diagnosed about 8 years late. Some features that can be helpful, but I have to say, I don't expect you guys to make the diagnosis of whether someone's having seizures or dissociative attacks. But it's more just so that you're aware of them. And if you see a patient who's known to have dissociative attacks, you know a bit about that condition. But also, it's very important that you keep this in mind, especially in the medical record, so that when we see the patients, it's helpful to know actually what happened in their attack. And that's the reason for mentioning the characteristics. So dissociative attacks, unlike seizures, only happen when someone's awake. This can even be when they're pretending to be asleep, but actually awake. How can you tell? Well, we can tell because if they're hooked up to an EEG monitoring device, then that can tell us if a patient's awake or not. Typically, it's associated with stress or depression or previous emotional trauma. Not always, but sometimes we see that. The attacks themselves, like in the video clip that you just saw, tend to be quite odd for epilepsy, but then that's something that we look specifically for. So it can be sort of thrashing movements, typically affecting the body more than you would see in epilepsy or tonic-clonic seizures, which tend to affect the limbs more. Pelvic movements particularly are suggestive of dissociative attacks. What we also call asynchronous movements. So in an epileptic seizure, movements are usually synchronous. It's one electrical discharge in the brain that causes the motor cortices to be activated. So you see the limbs move in sync. So if they're jerking, they jerk together usually. Whereas in dissociative attacks, you may see one arm shaking faster than the other arm. So that's what we mean by asynchronous movements. Head or body turning to the side, very unusual in an epileptic seizure. There may be sounds during the attack. Now, in epileptic seizures, people do have noisy breathing typically, and there may be a shout or a scream or a cry right at the start of the seizure. But in the rest of the seizure, there's not usually any other vocalization. There's not usually any other speech in a tonic-clonic seizure, I mean. Whereas in a dissociative attack, there may be stuttering or crying or moaning during the event. Eye closure can be helpful. So the eyes are often closed in a dissociative attack, whereas they're open in a tonic-clonic seizure. Some of the autonomic features of a seizure you don't see with a dissociative attack. So in some seizures, in some people with tonic-clonic seizures, you'll see the pupils dilate, the heart rate increase. And in many people, there's also urinary incontinence and then injury related to a seizure. Injury does happen in some people with dissociative attacks, but less commonly. And again, some people are incontinent during dissociative attacks, but again, less common. So I obviously don't want to, well, I don't have a clip, and I don't think it's right to show you a clip of someone having a tonic-clonic seizure, but this is the next best
Generalized tonic-clonic.
It is from Montreal, so there are French captions, but the narration is in English, thankfully.
Seizures never go unnoticed. Like their name describes, this type of seizure is composed of 2 phases, the tonic phase and the clonic phase. This is usually the type of seizure people visualize when they think of epilepsy. Essentially, the child will become suddenly unconscious and will then begin to experience a series of muscle contractions that involve the entire body. This phase lasts approximately 10 to 30 seconds and can begin with a fall, a sudden cry, and breathing difficulties. Next, the clonic phase will involve vigorous muscle movements that can last around 2 minutes. It is possible that the child accumulates saliva or loses urine or stools during this phase. Following a tonico-clonic phase, The person who has had the seizure usually experiences great fatigue and painful headaches. During the seizure, the parent must...
Okay, so I'll stop that there. I agree with everything in that. That's from a leading pediatric center in Montreal.
General...
So just to recap, so with a tonic-clonic seizure, that's when there's electrical discharge somewhere in the brain that's spread to both hemispheres. Often this electrical discharge can start in one part of the brain, what we call focal onset. And so before a tonic-clonic seizure, there may be odd symptoms, and these could be sensory symptoms, so tingling, for example, or motor symptoms. They could have jerking of one limb, which then spreads to loss of consciousness and generalized jerking. Or they could have in temporal lobe epilepsy. They could have a very weird, so what we call psychic aura, where they may feel the world's not real, or they're out of their own body, or they've got an intense feeling of deja vu, or a strange smell, usually an unpleasant smell, like a burnt smell. So auras and these symptoms beforehand can be very different, and they can be easily confused with someone having a psychiatric issue and a dissociative attack. So it's important to recognize that temporal lobe epilepsy can present with very bizarre auras. And there's one type, for example, if it involves the amygdala, where patients will just have intense fear, a sensation of intense fear just before having the seizure. And then, of course, once the electrical discharge is spread to both hemispheres, as you just heard in the clip, there's a tonic phase, which is shorter, and then the clonic phase. By this point, the person will have lost consciousness. They'll fall and go stiff at the onset, and this is the point at which they bite their tongue. After up to 30 seconds of this rigid, lack of movement and rigid posture, they'll go into the clonic phase, which is violent shaking. Sometimes not so violent, but typically, it's quite it's noticeable. It's the typical seizure that you see on TV, and this is a phase when they're incontinent. As you heard in the clip, most seizures, tonic-clonic seizures, will last less than 3 minutes, and that's important again when we're thinking about status and when to start treatment. Just to recap the different diagnoses that are possible for someone with a blackout. This slide you can come back to when the lecture's uploaded, so I won't go through all of this. But of course, the main conditions that we're thinking about are vasovagal syncope, cardiac syncope, dissociative attacks, as I said, and tonic-clonic seizure. So there may be a prodrome with most of those, apart from cardiac syncope, which can happen just out of the blue suddenly. Sometimes cardiac syncope can be provoked by exertion, working out, for example. And there are other triggers for the other types, which hopefully are straightforward. Dissociative attacks tend to be gradual in onset. There may be mild shaking or movements before it progresses to apparent unresponsiveness. A tonic-clonic seizure, I'll put as sudden, but be aware, of course, as I just mentioned, it could start in one part of the brain and spread. Fainting, it may feel sudden, but it's actually not too sudden. Many people don't actually injure themselves when they faint because there's enough time to actually lower themselves down to the ground and avoid dangerous objects. So, duration is very helpful. The longest, it may surprise you, is dissociative attacks, not seizures. Seizures don't last that long, as we just said. And cardiac or vasovagal causes tend to be much shorter with a quick recovery, as I put down here. Seizures a bit longer and a very slow recovery afterwards, up to half an hour before a person is orientated, but probably up to 24 hours in some people before they feel their normal self. Color changes. The only thing I would say is with vasovagal syncope or cardiac syncope, sometimes people, you can notice pallor. That's to do with the decreased cardiac output. In a seizure, it's different. It's not the heart that's the problem. It's the fact they've stopped breathing during a tonic-clonic seizure. So actually, rather than pallor, what you tend to see is cyanosis, especially in the lips. So it's worth asking directly, or family members may volunteer that. And of course, you wouldn't expect to see any color changes with dissociative attacks. Shaking doesn't really help. So even in a simple faint, people can have twitching. So it's not particularly useful. But the eyes are open in the cardiac, vasovagal causes and in seizures. Incontinence and tongue biting, of course, are more associated with tonic-clonic seizures. We tend to ask which part of the tongue is bitten, because lateral tongue biting, so the side of the tongue, as you can imagine, if your jaw clamps down and your tongue happens to be a bit to the left or the right, the side of the tongue can be bitten quite severely in a tonic-clonic seizure. You don't usually see lateral tongue biting in anything else. And of course, a seizure, as I said, slow recovery with confusion. With these two, cardiac syncope and tonic-clonic seizures, you tend to get injuries more commonly. As I said, a vasovagal syncope, a faint, it's quite unusual. Spent a bit longer on that than I planned to, actually. Okay, so the three answers: dissociative attacks instead of epilepsy, or yes or no. And the yes or no, so there's slightly different ways you'd approach a patient who has never had seizures before. And you want to think carefully about the triggers for the seizures. So trauma or head injury, pregnancy, of course, we're thinking about preeclampsia here, alcohol or prescription drugs, and there's lots. So I've just gone as far as B, but one trendy one in the current news climate that I'll mention is hydroxychloroquine can rarely cause seizures, so be aware of that. Illegal drugs, lots of these, so amphetamines, cocaine, ecstasy can cause seizures. And of course, neurological causes. So we talked in the last talk about stroke, meningitis, brain tumor. Many of those can cause seizures. In fact, brain tumor is much more likely to present with a seizure in the emergency department than with a new headache. The most useful thing you can do is actually take a witness account of what happened. And if I had the choice of either talking to the patient or to someone who actually watched what happened, I'd probably ignore the patient completely and just talk to the bystander, because that witness account is crucial in determining what that event was. And seizures are detective work. It's trying to figure out something that happened when you weren't present, with lots of incomplete information. So the witness accounts are really crucial, and some centres actually tell any acute medic or A&D staff to make sure there's a contact detail for an eyewitness before referral to the neurology clinic. So the diagnostic pathway, there's not much that needs to be done for a patient who presents with a new seizure. Basic observations, especially think about cardiac causes, so ECG, heart rate, blood pressure. A blood gas to look at the lactate, that can be helpful. Often lactate rises because of the anaerobic metabolism involved in the violent jerking, when you're not breathing in a tonic-clonic seizure. Temperature for meningitis, and then a few basic things, toxicology screen, pregnancy test if you're suspicious of that. Glucose, very important. Of all of these, one thing that you should do in everyone is a finger prick glucose or a blood glucose, or from the blood gas you'll get a glucose, to make sure it's not hypoglycemia or raised glucose, which can also cause seizures. Blood tests, again, you could get lab glucose, and then not many blood tests, but do remember magnesium, especially, not done in the routine blood tests that most people send off. Anti-epileptic drug levels, I've mentioned that again, but that's very helpful in people with known epilepsy. And a CT brain scan, I think that's useful in patients who've come with a first seizure, or even with known seizures but a different type of seizure, or if they've had a head injury as a result of their seizure, in someone with known epilepsy. But what I would say is, in people with known epilepsy, just because they've come after a seizure doesn't mean they need a CT brain scan. Think of all the cumulative radiation doses they're getting. I mean, I've seen people who've had 20 scans in a year, and they really don't need that. So in a known epilepsy patient, I suppose the key things to think about, ask them afterwards, or their family or whoever's with them, are there known triggers, and was that the cause on this occasion? The most common trigger for seizures in a known epilepsy patient is missing medicines. And that's why it's really important to send off anti-epileptic drug levels. It may surprise you, but you can actually send off drug levels for almost any anti-epileptic drug. They get processed in various centres, but the local one here is the Chalfont Centre for Epilepsy, and almost any drug can be sent. The useful ones for monitoring are only a handful, and it's mainly phenytoin, carbamazepine, and lamotrigine. But it's a very useful adjunct in terms of monitoring adherence. So if the level is 0, whatever drug it is, then you know they've been missing doses, and that's probably the cause of the seizure. The reason I put that in bold is that it's not something that I or any of the ward doctors can do later. It has to really be on that admission blood sample, because once we've charted up their anti-epileptic drug and they're getting it in hospital, there's no point sending off the anti-epileptic drug level. So you'll never know whether it was the missed medicines that caused the seizure. So always worth sending those off. Ask them a bit about the frequency and type of seizures. So, for example, if it's someone who has very frequent seizures, then you'll be less worried in the acute setting that something unusual has happened. Conversely, if you know they've had previous episodes of status, you may want to be more vigilant that they could go into status as well. And then regular neurological care. So if it's at the hospital where they present to, then it is worthwhile looking at the last neurology letter if it's easy to obtain. Out of hours, as it often is the case here, because that will tell you about the correct doses of the medicines, and you can cross-check that. It'll tell you about the diagnosis as well. As I mentioned, this is where you may pick up that someone's actually having dissociative attacks and not seizures, and that could be very helpful in terms of management. So you don't have to escalate them to ICU necessarily. And of course, you know who to contact in terms of the neurologist. And then management after that in a person with a seizure, especially if they're not known to have epilepsy. Driving advice often forgotten, but it is important to let them know about that. And the key thing here is that you're telling the patient they have to inform the DVLA. You don't inform the DVLA, of course. And the driving restrictions are divided into groups 1 and 2. If you don't know about this, and this is on the DVLA website. So group 1 is the standard driving license for a car or motorcycle. Group 2 is much more strict, and that's for people who drive buses or lorries. Minicabs are a grey area, so they're technically Group 1, but the registration is done by local borough councils, so the restrictions can vary depending on which part of the country you're in. But these are the national guidelines otherwise. So a single isolated seizure with no risk factors is 6 months off driving for a car, but if you're a bus or lorry driver, essentially it means you need to change your career, and that can be a very difficult conversation for us to have in clinic. Now, with no risk factors, that means 1 seizure with no underlying abnormality in the brain. And the way we figure that is by doing an MRI scan of the brain, looking for any abnormalities, and an EEG. Both of these are done as an outpatient setting, so not acutely. And they should have those tests organized by the neurologist, and then we can tell them whether they do indeed have no risk factors, or if they have a high risk of further seizures, in which case the driving restriction would be 12 months from the date of the last seizure. Similarly, if they've had a second or a third or any further seizures after their first one, it's automatically 12 months from the last seizure. There are a couple of exceptions depending on seizure type. So for example, sleep seizures or seizures that just comprise an aura, so funny sensation, and doesn't affect their ability to use all their limbs. But those are more complicated, and you don't need to worry so much about those. Provoked seizure I put in there. So if someone's had a seizure, let's say within the first week of a head injury or a stroke, or definitely due to drugs or alcohol or biochemical derangements, then sometimes the DVLA will let them go back to driving after 6 months. One thing that you may not know about is not so relevant in the acute setting, but anyone who's thinking of reducing their epilepsy drugs are advised to stop driving and to stop for 6 months after they stop their drugs. Bit of other safety advice that I tend to tell everyone if I see them acutely. The main one here is taking a shower instead of a bath. You may not know, but actually drowning in a bathtub, if you're face down lying in a bathtub, it takes very little water to drown. And as you can read here, it's the most common cause of accidental death. So showers, very important. It may sound counterintuitive because they're standing upright and they're more at risk of injuring themselves, but they won't drown. So that's within the home, and I tell them not to use any flames in the home because of the risk of knocking over a candle and starting a fire. Outside, a few common sense things. Again, I tell them to not go swimming if possible, or if they go swimming, make sure the lifeguard is informed beforehand and make sure the lifeguard's there. No climbing up ladders or doing DIY stuff that puts them at risk. No cycling without a helmet, no standing at the edge of train platforms. So it's all common sense things. And I tell them, just imagine, depending on the type of seizure they have, just imagine whatever situation you're in, are you doing the best you can to protect yourself from the dangers of a seizure in that situation? Okay. And of course, they can be discharged after an isolated seizure as soon as they've recovered fully and are orientated. You should really discharge them with another adult accompanying them, because the risk of a further seizure is highest in the first few days. So, yeah, and ideally they should be staying with someone as well. And then refer to the outpatient neurology service. Typically, most hospitals will have a first fit clinic and a pro forma that you can fill out and send. So on to the emergency that was actually advertised on the label for this talk. So convulsive status epilepticus. I've left it to the end because actually there's not that much to say, and there's a very clear algorithm that we can go through. So what is convulsive status epilepticus? So as you probably saw in the earlier slide, so convulsions are another term for tonic-clonic seizures. Both mean exactly the same thing, but rather than saying tonic-clonic status epilepticus, convulsive status epilepticus sounds a bit nicer. In contrast to non-convulsive status epilepticus, which covers all the types of prolonged seizures that don't involve tonic or clonic movements. And non-convulsive status epilepticus is much less of an emergency because people are still breathing during that. So there's none of the respiratory compromise that you see with convulsive status epilepticus. I haven't done any slides specifically on non-convulsive status epilepticus because it's much rarer and typically picked up and detected in the inpatient setting rather than acutely. But essentially the mainstay of treatment would be giving a dose of benzodiazepine, ideally as soon as you suspect it, but it can wait for an EEG to be done in the inpatient setting and then having the confirmation before giving a benzodiazepine dose. And the doses will be dependent on the person, so I won't talk about that just yet, but we'll talk about benzodiazepines here. So convulsive status epilepticus is actually surprisingly defined as seizure or multiple seizures without recovery lasting over 30 minutes. And that's from data that says after 30 minutes, people will have irreversible damage to their brain. But in practice, of course, none of us wait 30 minutes. In practice, we know that most people with tonic-clonic seizures will have them for up to 3 minutes. If someone's had a tonic-clonic seizure for over 5 minutes, it's unlikely to stop by itself. And that's the reason we start treatment after the 5-minute mark, because it's probably going to go on without medical intervention. Now, the guidelines that I'm going to use, they're the American Epilepsy Society guidelines on status, and you can just Google that and come up with the poster that I'm going to show you excerpts of. And this is the latest one, so it's from 2016, but it's actually valid even now. And we've had a couple of trials last year, 3 big trials looking at agents to use in convulsive status in adults and children. And it reinforces the guidelines that were already there. So the first step, we sort of talked about this, but these are common sense measures, doing basic observations, measurements, checking the blood glucose, making sure to replace glucose and thiamine. So if glucose is low, make sure you replace thiamine first, then glucose, and send off the drug levels if needed. Other things, I mean, if they're in a ward bed or hospital bed, make sure you remove dangerous objects, put the bed rails up, pillow under the head, again, think about cushioning the head. Recovery position, I'll put in brackets, that's only after a seizure. Don't try and move people, as we saw earlier, when they're having the movements. So in status, it's less applicable, but if you see someone who's just had a seizure, put them in the recovery position afterwards to just help their breathing. And recording duration. If there's family members there, it sounds weird, but actually getting them to record on video rather than doing nothing is very helpful for us as epilepsy specialists later in clinic to know what was going on, whether it was a real tonic-clonic seizure, dissociative attack, or a focal seizure. Okay, so yes, I've tried to put those as 3 R's to go along with the 3 C's. And the first real sort of medical step, if the seizures continue after 5 minutes, is to give a benzodiazepine. And this is what the guideline says. But to make it simpler, let's just summarize what it says. So the first step is a benzodiazepine, and we can divide that into whether you have IV access or no IV access. If there's no IV access, there's good data out there to say that rather than trying to get IV access, and this is particularly in the pre-hospital or paramedic setting, it's much better just to get on and give them a benzodiazepine by another route as soon as possible, rather than delaying IV access. In a hospital, it's less of an issue because someone can try and get IV access while someone else gets the medicines. So you've got multiple staff that can help with this. But if there's no IV access or difficult IV access, Intramuscular midazolam 10 milligrams is the best drug to give. And in a big study with paramedics, actually, that was better than IV lorazepam, but probably because of delay in getting IV access for them. Other options would be buccal midazolam, 10 milligrams, or rectal diazepam, 10 milligrams. So easy to remember, all 10 milligrams. Of course, buccal is easier to administer than rectal diazepam, which I think we should only use rarely now. If there is IV access, first-line drug is IV lorazepam, 4 milligrams. Okay, and hopefully you know that. An alternative would be diazepam 10 milligrams. You can and you should repeat the dose after about 5 to 10 minutes if there's no response. At that point, or even after the first dose, call the intensive care team, put out the medical emergency bleep, whatever it's called in your hospital. And you should certainly have got ICU involved before starting the next step. And typically, this is 20 minutes into the seizure now. And this is the second step, or what they've called second line agent, confusingly, because it makes it sound like it's not the optimal treatment, but it's just the second step. So after benzodiazepines, 2 doses, you come on to this step. These are the 3 agents. Now, this is an American guideline, so they talk about fosphenytoin. Fosphenytoin essentially is a precursor of phenytoin that's easier to administer IV. Phenytoin can be a nasty drug to give intravenously if it extravasates. So in America, they use that. We don't use that here, so we just use intravenous phenytoin. But the dose is the same because the PE here stands for phenytoin equivalence. So with phenytoin, it's just 20 mg per kilogram phenytoin. But again, let's just make it a bit simpler and take out phenobarbital, which is very rarely used, and come here. So this is what that step really says. The first line, especially in light of the recent trials, should probably be levetiracetam, not because it's better than phenytoin, but because it has far fewer side effects. And also, levetiracetam is a very good drug for someone to take in the long term, whereas phenytoin is often switched to something else later on after the infusion is given status. So there's, in a sense, what's the point in starting phenytoin if you're going to change to something else rather than just giving them something that they can take longer term? Practically, it can also be given very quickly, 15 minutes. I suppose the only real contraindication, and it's not an absolute contraindication, is to avoid it in severe psychiatric disorders. So levetiracetam or Keppra, I'm sure, is the most commonly prescribed drug nowadays, and is the default go-to drug for anyone with new seizures in hospital. And I think it's justified in the majority of those cases because it has very few side effects. The main side effects are dose-dependent drowsiness or irritability, so being short-tempered. And that's the reason for avoiding it in severe psychiatric disorders. Some people can get depressed as well with the drug. Other than that, though, it doesn't really have any other side effects, particularly no ataxia or unsteadiness or cerebellar symptoms, which some of the older drugs do, especially phenytoin. And it has virtually no drug interactions, which again is a very big bonus, especially in the elderly. Compare it to something like phenytoin, which you probably remember from various mnemonics in medical school. It's a P450 enzyme inducer, or sodium valproate, which is a P450 enzyme inhibitor. So levetiracetam has a lot of plus points, and that should probably be the first line. So it's no more effective, but it has fewer side effects than the other 2. That's the reason. So the next one is sodium valproate. Again, a very good drug, and again, it can be used long term. As you may know, there's new restrictions on sodium valproate use in women of childbearing age. So sodium valproate, of all the anti-epileptic drugs we have, causes the most damage to a fetus. And that's not just in terms of birth defects. Up to 40% of babies born to mothers taking sodium valproate may have developmental delay of some sort. So that's a huge number. So you definitely don't want to give it in someone where you haven't ruled out pregnancy. It's also hepatotoxic, so it's avoided in liver disease. Okay, and then lastly, we've got phenytoin. So lots of side effects. So it can be cardiotoxic, it can be neurotoxic in terms of causing ataxia. Then there's some rare complications, such as this purple glove syndrome, which is essentially distal limb, ischemia. So the easy way to remember the dose is 60, 40, 20 for those 3 drugs, okay, per kilogram. Going back a slide, there's actually far more epilepsy drugs, and some of these are new in the last 2-3 years. So there's 20 odd drugs that all work in different ways. And the main problem is most of these are not available intravenously. The only other drug that's commonly used that's available intravenously, apart from the 3 we've just mentioned, is lacosamide. And that's actually, so lacosamide up here, which is a sodium channel blocker like the majority of the older drugs. It works on a different type of sodium channel though, and it can be helpful in refractory status. So it is something that can be given IV and in the ICU setting if people haven't responded when they've got to ICU and still in status. But yes, otherwise we have limited intravenous options. And that takes us on to that last step where they should really be in ICU by now, and they need anesthetic agents to stop them physically seizing. And to actually, and they'll need ventilation as well because they're not breathing for themselves. So most people will need about 24 hours of intubation, ventilation, sedation before you can wean them off and have their status treated, usually by the second line drugs, so the levetiracetam or sodium valproate. And that's about it. So I'm going to stop there. Again, in the spirit of the last talk about COVID, the only thing I want to say is there's no risk that we know of with COVID-19 and epilepsy, but people with epilepsy frequently have infections as a trigger of their seizures. So that's the only risk in terms of telling someone about epilepsy, what to do about COVID-19. It's just the fact that they're more at risk and they should take paracetamol, for example, to keep their temperature down. That's it.
Thank you, and that was excellent. We have a few questions again. The first ones are around discharging a patient after a first seizure. How long do we wait before discharging a patient if all the initial investigations are normal and there hasn't been a further seizure? Is there a typical observation period we should be using?
So many places use 24 hours. I think that's probably a bit excessive. If they can go home with someone who can look after them, then actually people could go home a lot earlier, so 12 hours, for example, if the initial tests are normal. And as you saw, most of the tests are quite basic and you should get the results back quite quickly.
Yeah. And when this patient is waiting to be seen in the first fit clinic, should we be starting any medications or giving them any kind of rescue medications to take home with?
No. And the reason for that is that studies have shown that after one isolated seizure, and probably 4 or 5% of the population will have one isolated seizure in their lifetime, after one seizure, the risk of having further seizures overall in the whole population is about 25 to 30%. So it's not that high. Of course, if they have an abnormal MRI or EEG, the risk goes up a lot more. And after 2 seizures, the risk of having a further seizure is about 75 to 80%. So there's a big jump in the risk of a future seizure after a second seizure. What that means is most of the time we will start medicines in people after 2 seizures, because then we know that they're very likely to have further seizures in their lifetime. So that's why I wouldn't recommend that. The only exception is if someone's very keen to start treatment because they really don't want to have another seizure at all because the consequences can be too dire. But even then, I would talk to the neurologist on call first. I certainly don't think acute medicine should start any patients on seizure medicines. Yeah, the only exception is if you see people with some of the neurological syndromes I mentioned, like subarachnoid hemorrhage or brain tumor or meningitis. I think that's very different, and then it's worthwhile getting neurology input as an inpatient for those patients.
Thank you. Could you tell us a little bit more about starting thiamine before glucose in a patient with a seizure? Would you do this in all patients?
Generally, yes. I have to say I can't remember the biochemistry of why we do that, but it's yeah, we don't want to miss thiamine deficiency and give them glucose because it can cause irreversible damage, can't it? But I can't remember the mechanism by which it does that. I'm sure someone else could enlighten us on that.
Well, thank you so much for joining us this evening. We really appreciate you preparing these slides and coming here on a Friday night. And thank you for everybody listening in at home. I think that's it finished for the evening. When you